Gamma Pro, the precision probe. Designed from the ground up for precision surgery, its high-sensitivity detection crystal delivers unmatched accuracy. With a modern probe and tablet, Gamma Pro is simple, intuitive, and easy to use. Sterilization is simple and safe. Compatible with 9 different isotopes, and capable of detecting 3 isotopes simultaneously.
There's only one name you need to know. It's CubTech.
Welcome to the Mood Food Podcast, where we explore how food, medicine, and stories nourish the mind, body, and soul. Every 2 minutes, a woman in the US is diagnosed with breast cancer. But here's the hopeful news. Thanks to early detection and modern treatments, the overall 5-year survival rate is now over 90%, and nearly 99% when breast cancer is caught early. Today, we're joined by 2 remarkable physicians who are helping to change the story of breast cancer. First, Dr. Sunil Krishnan, a radiation oncologist whose research focuses on using nanotechnology, biologics, and botanicals to make cancer treatment more effective and gentler on patients. He's also deeply committed to serving the South Asian community through the Indian American Cancer Network in Houston. And Dr. Jessica Jones, a breast medical oncologist at the Mays Cancer Center, home to UTHealth San Antonio MD Anderson Cancer Center. She's the founder and director of the Cancer Risk Reduction and Education Clinic with a mission to prevent cancer, empower patients, and bring care to underserved Latin communities across Texas. My co-host, Dr. Pram, who is a naturopath, will also share her insights on integrative approaches using food as medicine, botanicals, and holistic practices to support patients through their cancer journey. Together, we'll take an informational journey through breast cancer from diagnosis and treatment to prevention, innovation, and whole person care. Dr. Jones, your career began at UTHealth Houston, where you launched the breast cancer prevention program. What inspired you to focus so strongly on prevention so early in your career?
Thank you, Dr. Pram, for that question. I have to say it started with the patient herself. I was initially hired on to be a breast medical oncologist, which is my subspecialty training. But as I was taking care of breast patients, as women who were struggling with this breast cancer diagnosis, I could not help but stop and think, one, was this even necessary? What if someone had just helped you 5 years before? Would you have even gotten this? And two, I looked at her and I heard her say, I am so worried for my daughter. And in that moment, I knew I not only want to take care of her, my breast cancer patient, I want to take care of her family. I want to prevent cancer. And that's what led the journey.
That's very powerful. Not just, the patient, but also the generations to come through. That's a huge, level of commitment that you need to have to put in that kind of work.
I also want to mention it's speaking from a woman to a woman that has such weight in the discussion and the trust that goes with it. Do you agree with that?
I do. I do agree with that. It is important for joint decision making for our patient with their doctor, knowing that you have confidence in what you're doing, what this doctor is recommending. You are moving forward with this treatment because you can, one, trust them. Two, they have educated, they have explained it. They're not just telling you what to do. You are an active member in this treatment plan. And lastly, this doctor is not only committed to me, I know she's committed to my family. And I think that really, I think the patients feel my true commitment to their cure. And I'm grateful. You're right. It's very powerful.
And you're genuine.
Thank you.
So you said no one deserves cancer and it is never anyone's fault. Could you share what that means for you when you talk to newly diagnosed patients?
I am so grateful that you've heard this comment that I've shared before, because it's true. There are people who are going to smoke and they're never going to get lung cancer. There are people who will drink alcohol or make poor decisions and nothing happens. There will be people who eat organic and they run marathons, and for some reason this person gets cancer. And when I think of this and I think of the person in front of me, I know the person in front of me is struggling and blaming themselves for this event that they had no control over. There are mummies in Egypt that have cancer, and that was before McDonald's and red dye number 40. So I often have to share, there's a lot we don't understand, but you did nothing to deserve this. You do not need to look back and blame yourself for one or another. All we need to do now is look forward and focus on our cure.
That's such a wonderful statement. I think, when people understand, this statement that you just made is, because I think at some point in their journey, they feel like they did something wrong,
Mhm.
and that's why they have to face cancer. And especially people who work really hard to, kind of maintain their physicality and all of, take care of their nutrition. They focus so much on all of those things. But somewhere down the road, they have kind of gotten cancer. So to understand the reasoning behind it is very difficult sometimes.
Do you feel that we all at some point have cancer cells that our body's fighting?
This is an incredible question and a proven fact that yes, our bodies have cancer cells that do not always manifest to the form of cancer that we see whenever a woman comes to clinic and takes care of me. Or where I am so sorry, excuse me, where I take care of her. I guess it could be both ways. I do have appreciation for life with my job. But I will also share that our body also has an inherent ability to repair itself, mostly while we sleep at night. But it is leaning into these other holistic measures that your question of does the body have cancer? And the answer being yes, I think also highlights we should also focus on wellness and how can we really lean into that part of our body that can kill those cancers.
Which is the natural killer cells that are always circulating and trying to do their job till something interferes with that process.
Mhm.
And I was just reading a study that said that, if I might say 5 to 10% is genetic, 40 to 45% is lifestyle, and 20% is maybe obesity with diabetes. So obesity is also part of that picture. I'm sure there are more factors, but it's something that I gleaned the other day.
No, I was going to expand upon what you have read. I think shows too the diversity in which we are now acknowledging different risk factors that lead to cancer. It is in the advocacy for research, not just in which medicines work, but looking back to say, what did this person have in their life that might have brought more, let's say, inflammation, or did it irritate the immune system? It is highlighting that we are trying to better understand why cancer happens, knowing that there's so many different variables that are weighed differently for different people. One is not necessarily the same as the other, even if both of these women have an estrogen positive breast cancer. I'm eager to learn more as we become more precise in understanding cancer.
Exactly.
I have a question that's, completely offbeat. Um, do emotions play a part?
I would say that is not offbeat. In fact, I would say the opposite. It is intuitive, and it is a variable that is not often accounted for, just as we don't speak about mental health often. There is research to show that life stressing events that lead to downstream outcomes, for example, living a lifestyle or having a job that is high stress, often leads to a high cortisol state, which may lead to a high inflammation state, or potentially also having an event where you've lost a loved one. And it is incredibly challenging to overcome that grief and not processing that grief. And what does your body do with that grief? These are questions that need to be answered and have been shown and linked to, yes, there is more connection with cancer.
How about staying in a bad marriage?
That is one that all the women that are listening to this podcast, if you're not already motivated, but then I would say that yes, there's some evidence to suggest that the unhappiness that a woman feels in her marriage is likely potentially linked as well. We haven't a very good way to measure it, but what I will say is that divorce during breast cancer treatment, over half the women that are married do actually go through divorce while they are undergoing breast cancer treatment, highlighting what I think you just shared. Is it unhappy marriage? Is that what may have caused it? Well, it may or may not have, but during her treatment, I think her appreciation for what is important and what she should stand up for often brings strength for a decision like divorce.
She will find her voice.
She will find her voice.
So I think that's kind of what I wanted to bring to this conversation is, for women to pay attention and advocate for themselves. It doesn't matter whether it's in a bad marriage or in a situation where, they're highly stressed, whether it's a job or anything else.
Like you said, the cortisol goes up and that throws the whole equation off.
Exactly. And for some of us, we, at a level of our DNA, some of us may be more susceptible to having DNA error or damage to our body from this versus others who may not. Some may not necessarily have as much damage to their DNA from this insult. I will say insult because it's an injury, but perhaps another person is more sensitive to pollution in the air, which can also lead to damage in our DNA.
Correct. So that leads me to ask the question, do environmental factors have a big part to play in something like breast cancer?
An excellent question that we often think about, especially the patient will think about frequently. Is it because I live here? Is it because I ate food brought from there? And I would say that we acknowledge that there are environmental factors that do lead to increased cancer. But right now, where we are in medicine, there is not necessarily a test I can order to say you had X level of microplastics or you had X level of arsenic exposure. But I am aware that this is part of the picture, that you cannot control where you grew up for the first 20 years of your life, potentially. So one day I hope we get to the level where we can answer this question to that degree. But until we get there, that is part of why I am so adamant to share with her, you did not do anything wrong. We are doing our best. And one day we are going to get this cured because we're going to understand not only how to stop it, but how to prevent it altogether.
Yeah, I think that's kind of, understanding the different factors that go into, causing breast cancer.
But we can do prevention.
Absolutely, which brings me into the role that I started with UTHealth Houston and now what I'm bringing to UTHealth San Antonio, which is primary prevention for patients that are at higher risk of cancer.
Wow.
So what would you advise them in terms of high risk?
I think a better question may be, am I high risk? How does one even learn this? And so I will share with you some of the challenges and barriers that a patient may have to understanding if they are or are not high risk. If a woman has a family history of breast cancer, if she has a personal history of complications of her breast where she may have had biopsies, even if they weren't cancer, it's still not normal for that to happen to her. If she had early puberty, or if she has gone through menopause, if she had later menopause, these are some of the factors, both that we cannot control, that lead to an increased risk of cancer. The other factors that can play into a woman's risk of breast cancer include weight, alcohol intake, the use of tobacco, the way that we exercise, our stress. There are certain risk calculators that can be used, oftentimes that should be employed in your primary care or maybe a gynecology office. But the amount of women who do receive this, it is less than 1%.
Okay. That's that should be the factors that should be taken into consideration, especially, for prevention, when they go to their physician even, for their yearly physicals.
That is where the perfect time should be. That is what primary care should be. But I will say it is not primary care's fault that this isn't able to happen. Our primary care system is riddled with an inundated with responsibilities and without having manpower. Moreover, as an associate professor, I also build curriculums, and a lot of the education for our trainees, it is not given to that level when they are in training. However, as a cancer doctor, I do have this education, which is kind of a conundrum because most cancer doctors, we don't get to meet someone until they get cancer. Yet we have the most knowledge in terms of why it may have happened and what we could have done to prevent it.
Right, right. So it's maybe something that should be brought into, um, a GP's, I guess, mode of care. I don't know.
It's pronounced Cubtech.
Cubtech?
CubeTech.
CubeTech?
CubeTech?
CubeTech.
CubeTech.
CubeTech? No, I'm kidding. They just told me that. Okay, Cubtech.
Cubtech. Cubtech.
It's pronounced CubTech.
It's Cubtech.
When it comes to specimen imaging, there's only one name you need to know. It's Cubtech.
I'm a naturopathic physician, and I do tomography, tomograms. And prior to doing a screening for tomogram, they have to go through a whole questionnaire of risk. And that's how I find out what their lifestyle is, what they're doing, what they're eating, all this, and early puberty, late menopause, all of those things. Number of abortions, miscarriages, all of those things are also important. So I do have a screening that way, in which case I can look at other factors for them, which is what I'm excited about what you do. Of course, you see it at after the diagnosis.
Well, I will say that what you are sharing with us is the absolute highest level of care that everybody should get and absolutely deserve. And thank you for modeling that for what we should all consider to be the best. But I also understand that potentially in some of our maybe lower income patients, such as Medicaid, I am presently in Texas, and we do have a good amount of people who don't have insurance and are often considered below the poverty level. I think a lot about these people, and this is why I've actually, as a cancer physician, as an oncologist, I have built a distinct space for patients that are not sick, that do not have cancer. And it is in this space where I meet them in their 30s, in their 40s, in their 50s, where we talk about, hey, let's talk about how to prevent cancer. Because I may not be able to fix the system for which they are currently receiving medical care, but I certainly know what I can do to change that. And that is outreach to the patient's family and being able to provide this space for them to receive dedicated preventative work.
At least you plant the seed for them to think about this stuff.
How do you explain the different types of breast cancer to patients and families in a way that helps them feel empowered and not overwhelmed?
I'm grateful for this question in particular because it highlights what joint decision making should be, which is one, making sure your patient understands what they have. So, as a general rule, breast cancer is divided into 3 different categories. The most common category is estrogen positive or hormone receptor positive breast cancer, another abbreviation being ER. There is another hormone receptor called progesterone that is lumped in with estrogen. The second type of breast cancer is one that shows a marker called HER2, or HER2 positivity. Now, these breast cancers may or may not also have estrogen, but this is considered our second category of breast cancer. And our last category of breast cancer, which for many years has been considered to be our most aggressive, but at the same time in the last few years have had the most advances, is the one that does not have estrogen, nor does it have HER2. And this is the one that we call triple negative, often most connected to genetics.
Okay. So when you talk about genetics, is the BRCA gene something that plays a part in this whole diagnosis?
Absolutely. The BRCA gene, BRCA1 and BRCA2, are our most common, or I should say, we have the most data on these two genes for their link to breast cancer. But there are many more genes that are linked to breast cancer. In fact, so much so that we have divided them into 3 different categories. High risk genes, where the risk of breast cancer is most certainly more than not having breast cancer, and moderate risk genes, where we're greater than average, but not quite to that 50, and then lower penetrance genes or lower risk, where yes, it's a little bit higher, but we don't know how much we should change screening just based on those.
Okay. And so this is easily understandable by our listeners, for our listeners. I just want to kind of make sure we have that, whole explanation for it. What is the role of a breast medical oncologist in a patient's treatment plan?
Well, I'm certainly not going to say I'm the most important, but I will say that I'm going to be taking care of her the longest. As a breast medical oncologist, my role in a woman's breast cancer journey is to help her with whatever medical therapy, whether this is chemotherapy or whether this is hormonal therapy or immunotherapy, to help enhance her cure. I work with both breast surgery, which is our curable, that is the curative step for breast cancer, as well as radiation oncology, depending on a woman's surgery. So the 3 of us work together to cure cancer.
Okay. So in other words, you have a team of doctors attending to every patient to customize care for each person.
Exactly.
And so when they come to you, are they just talking to you or they're talking to the team?
This question highlights, honestly, what I wish would be the perfect level of care where a woman could meet all 3 of us on the same day. That is something that we call multidisciplinary care. But often, a majority of patients will meet their physicians, their medical oncologist, their breast surgeon, and their breast radiation oncologist on different dates to learn about that which each offers.
Okay. Okay. So it's not necessary that the whole team meets them together. It's individually then.
Individually, yes.
Yeah. Okay. And so, what are the different, questions a patient should be asking you?
A woman often, because we aren't ever prepared for cancer, there is never enough time to know what we should know. So I have these recommendations depending on your type of cancer. So if a woman has a hormone positive breast cancer, my recommendation to her would be, number 1, to your medical oncologist, ask, what is my cancer and do I need chemotherapy? Since not all women with estrogen positive cancer will need chemotherapy. To her breast surgeon, I would recommend that she ask, what surgical options do I have? These breast cancers are often found on screening mammography, so a woman does not have to necessarily have her entire breast removed. And to a radiation oncologist, I would also ask, do I absolutely need radiation? Now, this is controversial, and I know that if there's a radiation oncologist listening, but there is more data. There are lots of studies ongoing right now looking at the omission of radiation, and a woman should feel comfortable asking, do you think I'm one of those candidates? If a woman has either HER2 positive or triple negative breast cancer, she should be mentally prepared to hear about chemotherapy with or without immunotherapy. And this is because in the world of medical oncology, we are enhancing cure for these 2 types of cancers by utilizing medical therapies such as chemotherapy and immunotherapy before surgery. And so, to that, the question that she should ask is one, do I absolutely need these medicines? Two, what side effects am I supposed to experience? And three, will this change my surgical options? Since oftentimes by giving chemotherapy first, we may be able to help a woman have less invasive surgery.
That's perfect. Just for our listeners, I wanted to break it down for them. So what is the difference, like chemotherapy and immunotherapy? These are words. How would you explain it to a patient? What does it mean?
Yeah, it is. It is something, I say something, it is a definition that continues to evolve in the world of oncology as we become more precise with both targeted therapies and hormonals and such. So a when a patient or a physician talks about the IV, the intravenous medications given, oftentimes will generically refer to the combination as chemotherapy because historically that's all we had. But chemotherapy is what we call cytotoxic, or in other words, it is a medicine that directly kills rapidly dividing cancer cells. This is different, but often used in combination with immunotherapy, where immunotherapy, there are different types. In a HER2 positive breast cancer, this looks like an antibody where we are giving a medication that has the ability to recognize that HER2 target. Immunotherapy in triple negative is a medication called a PD-L1 inhibitor, or it is a medication that helps your own immune system unhide cancer, because cancer can try to hide from your immune system. And what this medicine does is it takes away that hidden quality and lets your body recognize cancer to then kill it and then hopefully develop an immune response.
Wow, that's amazing.
That's perfect.
Yeah.
So would the immune response mean an IgG kind of a reaction, or where the immunoglobulins are now protecting?
What the reaction one should anticipate when we talk about the newest form of immunotherapy or the PD-L1 or PD-1 inhibitors, it is a therapy that lets our T cells attack the cancer. We were talking earlier about natural killers and these very potent cells that are meant to protect our body. This is the exact reaction. We are looking for our T cells to activate, killing cancer cells, which then brings the rest of our immune system to the table to try to do their best as well.
Okay, sounds good.
I am grateful to be able to explain a little bit about our immune system. There are different ways that our body is meant to protect us. But earlier we had mentioned, is there an IgG response? And what that question was asking is, does our body have memory to look at and recall and kill cancer? So to a patient, I would say, I want you to think about your flu shot. You are given a flu shot, not because we're giving you the live flu virus. That's not it at all. We are giving you parts of a virus so your body can recognize it, find a way to attack it, and then that part of your body makes memory. So whenever, heaven forbid, but let's say you are exposed to the flu, your body says, I remember that, and then goes to then develop IgG or develop these antibodies to then defeat the virus. There is ongoing research right now looking at the use of vaccines in breast cancer. Not quite ready for prime time, but stay tuned. I think you'll be very excited to see results in the next 1 and 2 years.
So I also want to bring light to, that chemotherapy is not just one route. There could be multiple routes. So what are the different chemotherapies?
Whenever a woman is offered chemotherapy, when she is offered a medication that directly kills cancer cells, this may be offered in the form of IV or intravenous. There is often, though, another opportunity where we can give pill forms of chemotherapy. Now, if a woman is going for curative intent medical therapy for her breast cancer, we will be using IV formulations of these medications. Oral versions of medications are offered to women that, one, after surgery, we want to enhance her cure, or two, women we cannot cure, but we want to control the cancer.
So I'm going to be specific on this. The oral ones are given post surgery for women that need extra care.
Exactly. But if it's okay, I'd love to spend just a minute or so sharing this, since it is innovative and it is groundbreaking and it is changing the way we cure cancer. By giving a woman the IV formulation of medication before her surgery, while she still has cancer in her breast, we are able in real time to see how well that medication does in killing cancer. So while we are giving this medication, if your physician offers it before surgery, you should expect the benefit of feeling or seeing, if you can feel or see, the actual difference in the tumor. By the time a woman goes to surgery, we're able to look under the microscope to see, hey, how well did that do? I mean, this medicine is very good. It should have killed everything. In a perfect world, that's the hope. So when we look under the microscope, because we have to confirm it's killed, that is why we have to do surgery for curable cancer, we're able to say, hey, it's all gone. And if it is, that's great. That means, one, the medicine was able to kill 1 billion cells, which is a tumor. So while I do not have the technology to tell you right now who it might have been floating around in her bloodstream or did it try to hide somewhere, if it did, and if the medicine killed all those other cells, we feel very good that it also killed anything microscopic. Now, there's a flip side. What if the cancer wasn't all killed? What if there was some cancer cells left over, even if it's only 3 cells? Well, there's only 2 reasons for that. The first reason is, one, did she need more medicine? That's one reason. But there's limits to the amount of medicine we can give. We can't give enough. There's dose limits. Or 2, the only other reason that there may be even 3 cells, it would not have mattered if I gave her 100 doses. Those 3 were going to be resistant. I would only know that if I gave her medicine before her surgery. And if we do know that, this is very powerful, because it can change the way we help her after surgery, which, as we had said earlier, what about those pills? What about those pill chemos? That may be a time where we say to her, hey, yes, this happened. Yes, there were 3 cells left over, but wait, we are going to do something different. We are going to add an extra pill, an extra chemo, or an extra hormonal, or insert blank. Because one, if you needed more medicine, I'm going to do that. Or 2, heaven forbid, but if it was resistant, I'm giving you something new the cancer hasn't seen. So by giving her that medicine, 2 birds, 1 stone, and that is how we're curing cancer better than ever.
That's a great way of explaining the whole process. Mm-hmm. So the next question that I would have for you, Jessica, is, are there any side effects?
There are a plethora of side effects for any of these medications. And that is my responsibility, and I must be held accountable to sharing that with my patient. And so what I often do is share with her the most common, to which I will say, look, we just got to be prepared for the most common symptom is often nausea and vomiting. But because we know that, we also change the way that we give these medications. If I know that nausea and vomiting is the most common symptom, not only on the day of medicine will I give her anti-nausea medicine, but I'm going to be proactive and I'm going to schedule anti-nausea medicine for when you're home because I don't want to wait for you to throw up or feel sick. We are going to be ahead. And so the second most common symptom is going to be fatigue. This is a symptom that I can't control. But when I do share fatigue, I say that you should not be comatose and you should not be lying in bed all day. What this may look like is maybe we don't do the dishes. And that's okay. No one died from not doing dishes. The third most common side effect is oftentimes going to be something with our stomach, whether it is constipation or whether it's diarrhea. In any case, just as I share with nausea vomiting, we're going to be proactive. So if you get constipation from this medication, I would want you to do what you would have done anyway at home. I will never forget a patient told me, Dr. Jones, every time I get constipated, I just go to Taco Bell. And I just did not. So if that's what you do, then we should do that. And when it comes to diarrhea, I would say, you know what? If you get diarrhea, do what we would normally do. You would take Imodium. The next most common side effect is often a reduced immune system. But because I know that, if I know that that can happen, we change the way what we do the next day. And oftentimes what we do is I will give you a medicine to boost your immune system. So you will not be locked in your house. You don't have to miss that T-ball game. You can still go to the grocery store, but I would ask my patient to stay mindful of wearing a mask whenever we see people coughing, or maybe we just avoid sick people. These are the 5 most common symptoms. And of course, depending on which medicine she's given, some more rare side effects can occur. But to each one of these, the physician should spend that extra time going over them.
True. Right. So those are the important ones that you suffer right away. And then there's
hair loss. We were both hair loss. I live in Texas. I provide medical oncology care to patients in Texas. My patient's insurance will not cover the use of equipment that can help a woman not lose her hair. So what I do prepare her for is, yes, women will lose their hair on this therapy. There are ways that we can mitigate that. There are devices, there are caps, there are different opportunities, but technically, nobody died from being bald. I'm not saying it's right, everybody. I'm just saying because of this, insurance won't pay for it. I would love for them, and I always offer, here's some information so you can make this personal decision if you would like to purchase this on your own. Cancer care is expensive. There are a lot of invisible burdens connected to cancer. Emotional, there's family, you're often a mother, you're a sister, your job. So recognizing that, I do my best to give her every opportunity while at the same time normalizing that if you don't choose it, that's also not wrong.
Right. I mean, that's fair. You give the patient the choice to whether they want to be able to take care of that or, just be who they are at that moment.
Exactly.
Yeah. So, Dr. Brown, what role does food and supplements play in supporting the patient's journey pre and post treatment?
Well, I think when you look at the expectations, you prepare them that way, like what you can do, maybe build yourself up, build that immunity up. So when you do take the chemo, it's not going to bring your immunity down to your ankles, but, just give them enough to keep moving. Once they're on the chemo and they're having side effects, you can give them the anti-nausea medicine or whatever. We can support them with diet, keeping the microbiomes alive and well, keeping the gut lining healthy so they don't end up with leaky gut or some other issue that might come from it. So we're constantly engaged with the patient.
Well said. Well said. You're absolutely correct. We should stay mindful that there's many different opportunities to employ our best health that aren't necessarily related to medication or drugs or scans. There's a lot of natural ways that we can do this. Now, I will say that as an oncologist with in the medical system that we live in. I may not always have the most time to go into this, but for this, I would say to a woman, if you do have these questions, and if your doctor is not answering them, number one, let's talk to a nutritionist. Most cancer centers are affiliated with nutritionists. Or two, patient advocacy groups. There are some wonderful patient advocacy groups online that do spend a lot of time and have had a lot of energy into this, knowing this is something we want to know. And lastly, I would say if there is something you want to add to your care, I have a good amount of patients that want to do vitamin C infusions, or they would like to add to their therapy that is not covered by insurance, but they want this. I say, please just tell me what you want to add, and let me just make sure it doesn't interact with the chemotherapy, because if it doesn't hurt, it might help. I'm not going to tell you not to do it. I would love to do that with you. So to that, I would say just one-on-one, making sure we're open with your doctor so they can support you the best way they can.
That's a great integration of two different worlds. And I think it's important in today's day and age to address that, because our medical system doesn't really allow for that a lot. I don't think even the education of physicians, it's not their fault, they get any part of this, really.
And that's why it's complementary.
It is what I wish we all could add. I know that I do my best to be the best educator I can for our joint decisions, because at the end of the day, it is my job to make her life better. And I also know that the way that she eats and how she eats, or adding probiotics, I do know a lot of this can make her life better. So I do try to find these opportunities. But I think one of the most important diet comments that we need to say, we need to address sugar. So a woman will often come into my office and say, I completely cut sugar out of my diet. I really want to eat that piece of cheesecake. And to her, I say, look, the cancer is already here. We do know that diet, inflammation, sugar, yes, these things play a role, but we don't understand it totally well. So I do not want her to be held in fear of anything she eats. Instead, what I say to her, medicine is going to work. And in the future, when we get you cancer free, let us talk more about sugar. Let us talk more about diet. That is a long game. And right now, you need the support your body needs with the medicine and what makes you happy. And so to each, I say, yes, I would love for you to be as healthy as possible. But at the end of the day, that is after you're done with your surgery. And when we're talking about keeping you cured, that is when I really want us to lean into diet.
Absolutely. Absolutely.
That's wonderful. So I think, one of the questions that I think is important is, what advice do you have for the families and friends of those patients? How can they support themselves and the patients during that journey?
What an excellent and amazing opportunity to share that your family member, your friend, your loved one that has breast cancer, they are scared. They are worried. They don't want to be a burden. They don't want to ask for help. And it is already hard for them to talk about their journey. So what I would encourage anybody listening, if you are listening for a family member or you are having someone you know or love, offer to take them to that appointment. Offer to come over and bring dinner. Let them see you clean the dishes without being asked. Do that extra step. I have never had a family member or a patient say that they didn't like it or that it was a bother. I've only had patients and loved ones say, I regret not doing that. So please take that step. They are not going to they will not reach out to you. They're already overwhelmed with information. Go there, do the extra step for them, take out the garbage. I promise you, even something as small and simple as this, it stays in the heart and it gives strength throughout all the hardships to come.
That's very good advice, because considering women never ask for help. It's very difficult for women because they take care of everybody else. It's very difficult to say, I need help. And so, when people come out and do that on their own, it's very, very heartwarming and very helpful.
Oh, absolutely.
Yeah.
It has to be, it takes a village.
It takes a village. And what can you imagine as women what we can accomplish if we lived as a village all the time? And so if only, I wish this for all women, to always have that village. But if she didn't have it before, my goodness, there is never a better time than to lean in during your treatment.
Correct.
So I see that you have been very involved in your community as well. I just wanted to learn a little more about that. You're very focused on reaching Latin and other underserved communities in Texas. What barriers do you see in these communities that these communities face in cancer awareness, screening, and treatment?
We live in a very interesting time right now, don't we? And so it's not a topic it feels like we're allowed to speak on, but it is a topic that is close to my heart. There is a gap in the cure. There is what we call morbidity and mortality. Something that what this means is the cancer that a Hispanic, Latina, a Black American, a South Asian, East Asian woman, all of these women that are of minority compared to Caucasian backgrounds, they have a more aggressive cancer. Regardless of underneath the microscope, it can look the same, but we know, research shows, there is a difference. And my heart and my work is dedicated to this group because I know that if I can cure, if I can help, if I can reach our sickest patients and make it better, I make it better for everyone. Everybody wins. So yes, my community, even now, my family is in the uninsured community. My family, I'm a first generation physician, a first generation college graduate. My brother and I were the first ones in our families to do this. And so it is very close to both of our hearts to be able to commit to the community that we grew up in. And my commitment knows that when I help her, I help everyone.
And this is such an important aspect of doing what you do. I was telling Dr. Krishnan as well, I think I consider physicians to be doing a very noble profession. It's a very noble profession, medicine is. And when you just extend this to just about anybody and everybody, and inclusive of, it's a very inclusive thing to do as opposed to just having served, let's say, high, income people, and because they have the care that they need, they have the resources that they need. It's the low income people that struggle with this. So it's fantastic to learn that there are people who are actually trying to help them, yeah. And so what message would you give to women in underserved communities who may be hesitant to come forward for screening or care?
I would like to share with her, if you are a woman that has been hesitant, if you have been a woman just on the edge, oh, I'm so sorry. I know there's some sirens in the background. Can I restart that? Okay. To the woman that is on the edge, is not quite sure if she should move forward with her screening, if she is a little hesitant to go to the doctors, that what have they ever done to gain your trust to begin with? I don't blame you. I am here to validate you. You're not wrong. The medical system was not designed and is not helping those of us that need more because of how this is all structured. But instead, I would say, please don't lose hope. Please prioritize yourself. You need to know that there are physicians. The three of us on this podcast, I think, are a testament to it, that we will not give up the fight. We will not stop trying to make the world better. And when it comes to cancer, I know that cancer patients are going to need dedicated, passionate, just empowered physicians like myself to keep going. I will find that cure, but you need to know to trust us, to trust me. And that first comes with you taking time to take care of yourself. So please go get the mammogram. You're not going to give yourself cancer. If anything, what you're going to do is find something if it's there at its early, most curable stage, so you can still be the woman, the mother, the sister, the friend, the daughter that you are.
That's a very powerful message, Dr. Jones. So one of the last questions I think I want to ask is, how do you inspire the next generation of physicians to think about prevention, equity, and patient advocacy?
Well, I hope that by my modeling what I also hope to be the best level of care is one way that I can support our learning physicians, our trainees. So I would say one of the best ways that I can model this, one of the best ways to ensure or at least hope that they leave with equal passion and dedication to the prevention of cancer. Not only one, do I do my best to model and educate, but two, I am very intentional in taking my time to build curriculums and help build educational content for our trainees. So even if you don't get to hear my voice personally because you're not with me in this medical school, there are still opportunities that I can reach you with the curriculum and educational development that I do with others.
Thank you so much for answering the questions so beautifully and empowering a lot of people in making good decisions throughout their, cancer treatment journey.
Thank you again for this opportunity. It was a delight and an honor to be on this podcast and to share the messages that I know we all have close to our hearts.
Thank you so much, Dr. Jones.
Thank you so much. It was a great pleasure to meet you.
It's an absolute pleasure to meet you. Dr. Jessica Jones Trevino was amazing. Now we're going to hear from Dr. Sunil Krishnan. So the first question obviously is, can you share a little about your journey as a radiation oncologist and what drew you to this field?
Yeah, I trained in India as a medical doctor and then came to the US thinking I wanted to do oncology because I had seen some amazing things in my medical school where they were doing transplants for leukemias and curing patients. So I thought I wanted to be a medical oncologist, came here, did an internal medicine residency leading up to medical oncology. But somewhere during residency, I learned about this field called radiation oncology and realized that that was a nice sort of convergence of engineering, physics, and biology and medicine. And it just appealed to me because of that intersection between the physical sciences, the biological sciences. And so I went and did a radiation oncology residency after that. I did that at the Mayo Clinic, and then I've practiced as a radiation oncologist ever since. Spent 15 years at Anderson, MD Anderson in Houston, and then went back to Mayo for 3 years, this time in Florida, and then just came back to Houston to be at UT, where I direct the radiation oncology program.
So you've been in all warm places.
Yes, after that short sort of stint in Rochester, Minnesota, I thawed out after that stint in the cold and haven't gone back.
So you prefer the warm weather, of course.
Yeah.
Or you miss Minnesota?
Yeah, no, it's friends and the ecosystem that mattered just as much. So the ecosystem at Mayo is great, but the warm weather in Houston's appealing. And the Texas Medical Center is a huge conglomerate of multiple hospitals, medical schools, graduate schools. So it's a nice cluster of institutions all grouped together within a, 3-4 mile square radius.
So it sounds like you're very involved in the whole cancer scene. And many times when a patient, especially when we're talking about breast cancer, hears about the possibility of radiation or you need the radiation therapy, How do you approach that?
Yeah, I think because it's something that most people have not experienced before, it's a little unnerving. And then because it's a somewhat techy, jargon-filled field, is also a little disconcerting. But once patients get to understand that it's similar to just going and getting a chest X-ray, except that the radiation beam is on for a slightly longer time instead of a few seconds, a few minutes. You don't feel a thing, and it's fairly well tolerated. Most patients are able to sail through their treatments without any trouble. The biggest challenge is maybe a little fatigue and the skin getting a little red, sort of progressing from a suntan to a sunburn in the worst case scenario. And it's gentle. You do this over 3 to 6 weeks, and patients can come back and forth by themselves. They're in the department for, I don't know, on average less than 60 minutes, including parking, waiting for the patient ahead of you, getting into the treatment room, and then staying in that room for less than 15 minutes and you're done. So it's a fairly painless procedure.
So, Dr. Krishnan, you have to determine how many rads of radiation. How do you figure that out?
Yeah. So the reason to give radiation most of the time in breast cancer is to reduce the risk of recurrence within the treated field, which is on average about a halving of risk of recurrence. And the reason to consider doing radiation is to avoid a mastectomy. A mastectomy means removing the entire breast. Whereas if you do it with this sort of breast conserving approach, what you do is a small partial breast tumor removal, removal of the partial breast, they call it a lumpectomy, and then follow that with radiation. And the data are, if one were to spread this out over 5 to 6 weeks, it's very low doses of radiation. But if one wanted to compress it into 3 weeks, then it's a modest dose of radiation. And then if one does very compressed course of treatment, it could be just as little as a week. And then it's much higher doses every day. So it's customized to patient preference, logistical challenges with coming back and forth, things like that. So the cumulative effect of all these regimens is the same. That is, that they reduce the risk of recurrence and prevent the need for a mastectomy. But how you give that, do you give it in small packets every day for 6 weeks, or do you give it in slightly bigger packets in 3 weeks, or very big doses? That can be customized, depending on location of the tumor as well, not just entirely based on patient preference and logistical considerations.
So my question is, many patients fear radiation because of the stories of the side effects. How is modern radiation therapy different from what, people might expect?
Yeah. So the one thing to remind patients is that not all radiation is the same. So if they've heard of significant side effects from other friends or family who've had radiation, that may be a completely different scenario than what they're experiencing and what they're going to be going through. For instance, head and neck cancer patients, you give a pretty high dose of radiation and the skin gets quite red and raw. Say cervical cancer patients, you give some external radiation from the outside, and then you put applicators into the pelvis and give internal radiation. So the side effects of radiation depend on the site you're treating and the dose of radiation you're giving and how it's administered. In the old days, when you used just cobalt machines, cobalt is a radioactive isotope, and that was put on an arm that goes around you and gives radiation from different angles. In those days, the skin would get quite red and raw and blistery. But we don't use those radiation machines anymore. Current linear accelerator kinds of radiation machines, you can sculpt the dose to be confined to the vicinity of the tumor and minimize the dose to the skin and surrounding normal organs. And then, as needed, you can take this X-ray radiation and refine it, say by using an arc that goes around the body and continuously shapes the beam as it goes through. One can use protons, which are particles that go straight into the tumor but stop at the back end of the tumor so that there's no dose behind the tumor. So there's many ways of giving the radiation these days that have reduced the toxicity, specifically for a breast cancer patient, especially a left breast cancer. There's the fear that you might give an unnecessary, unintentional dose to the heart. And so one can have the patient hold their breath, get an image, make sure that you're staying away from the heart, and then shoot the beam of radiation. So there's many ways to fine-tune the radiation.
Okay, so it's nothing like it used to be before. It's a lot more milder. So the toxic, should I say, side effects are reduced tremendously from the radiation doses, and it's very specific and outlined essentially.
Right. It's focused and very targeted.
So the point is that when people come to you, and do they have some kind of myths or misunderstanding about radiation and they're fearful about it? Do you have people in your immediate trying to help them understand what it is, or do you do all the talking for them?
It's a team approach. It's usually the physician, oftentimes a nurse practitioner or a physician assistant or a resident, providing the technical medical advice. Then there's always a dietitian that'll counsel about diets. There's a social worker that can help with sort of making the process of coming and getting treatment less burdensome. And then, as needed, you rope in other partners. If there's a need for bringing in someone on the behavioral side, you do that. It's a team effort.
So how do you decide when radiation is the right choice in a treatment plan?
Right. Sticking to breast cancer, if the choice has been to go with breast conserving therapy, then if the patient's had a lumpectomy, then the traditional recommendation is to get radiation after that. In small subsets of patients who've undergone a mastectomy, one may end up having to give radiation in addition to the mastectomy. And all of these are based on the risk of recurrence. We know that the risk of recurrence is higher if one undergoes just a lumpectomy, and so the radiation's added to reduce that risk. And oftentimes, despite doing a mastectomy, the risk is high for a recurrence, especially if it's spread to lymph nodes. Then there's a need to reduce that risk, and then radiation's added on top.
That's interesting. So, from what I understand, once you've had a mastectomy, you don't even need to go for a mammo anymore. So, I would think it would reduce the risk tremendously, but it sounds like that could be it could be different in different scenarios. And that's why it begs radiation, essentially.
That's right. Yeah. But the traditional scenarios that one encounters is someone who's had a lumpectomy and then is getting radiation.
Okay. So usually it's not after a mastectomy, it's after a lumpectomy.
Right. Yeah. If one can avoid a mastectomy, one avoids it completely. If one cannot avoid a mastectomy, the hope is to avoid the radiation. But sometimes you end up having to do both. And then you're stuck with the sort of side effects of both treatments.
Okay. And so, this is it's good for our listeners to understand, what role radiation plays in the whole treatment. They could avoid a mastectomy, possibly, if they get radiation post a lumpectomy. Is that correct?
Yeah.
Yeah.
That's correct.
So how do you minimize the side effects of radiation? How do you approach that?
Yeah. So there's a few things one can do to reduce the side effects of radiation. During the course of radiation, it's helpful to not be smoking because that increases the side effects of treatment. So we counsel everyone to stop smoking. The skin will get a little red, like I mentioned. That we give them creams and lotions to start with healing of skin as soon as that occurs. The fatigue is a little more challenging. There's no sort of countermeasure to overcoming fatigue. So we tell patients to just pace themselves, know that if they were running a mile on their treadmill and they're able to only do half a mile, that's okay. Don't have to push oneself too much. If because of the fatigue, if one were to go to bed an hour early or wake up an hour late or take a siesta during the day, that's okay. And then we advise them to maintain some level of activity to the extent possible and maintain a healthy diet. The dietitian usually will guide them in terms of what the rough guidelines are to not lose weight during radiation, but also have enough calories and enough protein in their diet. Aside from that, we're not, with breast cancer radiation, we don't run into too many other issues. But if there are reasons for the patient to have nausea or diarrhea, we'll give them medicines for all of that, but not in a breast cancer patient. Sometimes when you're treating the nodes in the neck, you could have a little difficulty with swallowing, and if so, they get something that coats the inside of their food pipe that helps swallow and, again, not lose weight.
So, there's sort of an inflammation. You feel like you have a sore throat or something like that.
Right, exactly.
Okay, so that could last for some time?
As soon as the radiation ends, it'll start getting better, and within a week or so, you should be completely fine.
So I just wanted to understand. So, Dr. Pram, I would ask you to kind of, lean into this and say what's nutritionally, a good way to kind of combat these side effects.
Well, of course, diet is an important thing. Lifestyle is important. Sleep is important. These are all things that we do on a daily basis. But I think looking at having foods rich in antioxidants, which help to rebuild the tissue and make it stronger as it goes through the process. Eating protein, which are important again, especially the collagen to build up the tissue again. And hydration is important too. I mean, without hydration, you're just
right.
It's just not going to move things. Like we say in natural medicine, the body has to clean itself, and it does that through the urine, through the stool, through the skin, and through the breath. So we allow those things to work in favor of the patient's healing process.
Okay. And do you kind of counsel the patients on these things as well?
Yeah, that's how I explain it. Very similar to how you explained it. I think of it as radiation is not a silver bullet. It doesn't just kill the cancer cells. It kills the cancer cells better than it does normal cells, but it also damages some normal cells along its path. And to bounce back from the side effects of radiation, think of rebuilding that wear and tear caused by radiation. And the building block of the body is protein. So having adequate protein in one's diet is good. The jury's kind of out on what the antioxidants do. So I don't advise my patients to take excessive amount of antioxidants because radiation exerts its effects by causing oxidative stress. So then, granted, we don't have any data to say that antioxidants are counterproductive, but just it intuitively makes sense to me that an antioxidant at very high doses or supraphysiologic doses would be,
I would say mostly in
not
terms.
ideal.
I would say mostly in terms of food, like green
Yeah,
tea, berries, cruciferous vegetables, things like that,
that's right.
which are more in their diet rather than give them a pill.
Yeah,
Even
that's
the
exactly right.
protein, the lean protein, is important again from the food source than another pill.
Yeah, exactly. And then after the radiation, if one wants to take a little higher antioxidant for prevention, that's not unreasonable.
You're very passionate about serving the South Asian community, and you're involved with the Indian American Cancer Network in Houston. So, what inspired this work, and what is it that the network does?
Yeah, it was started by a friend of mine. We all sat down together when she came up with the idea. She used to work at Anderson. I think she was a histopathologist and she'd retired. And she wanted to give back to the community in some way and realized that the South Asian community in Houston is quite large. We have over 150,000 South Asians, Indians, and Pakistanis, Bangladeshis, I think. And we're often seen as a model minority, that everyone feels that this community is well off and well educated, and surely they'll have no issues with accessing healthcare and making decisions. But we found from friends and family that there's still a dire need for people to be helped along this cancer journey. And so she and a few of us got together and created this small nonprofit. At the time, the idea was to break ourselves, this handful of us, into 3 groups. So there was a medically knowledgeable group, and then a more social service kind of group, and then a survivors group. And so we said we'd have a intake mechanism. If someone calls in, we would take turns and triage and decide which group would be the most helpful. If someone's just been diagnosed, they don't understand what a biopsy is, how is it different from a fine needle aspirate. So there's a lot of jargon, and deconstructing this jargon would be helpful. And that's what the physician and allied medical professionals were helping with. And then there were issues like if you lose your hair during chemotherapy and you needed a wig, would you be able to find the right kind of wig? It can, if it's an Indian patient, it may not be a blonde or a redhead wig. So can you get some salt and pepper or a black hair or something like that? Or we would help with meals, bringing them something that they're more familiar with, would help with transportation. So that was what the social group did. And then there was another group that was survivors, someone who's been through all of this before, who serves sort of as a buddy network, who you could reach out to and they would tell you what they're experiencing, be it sort of mood related changes, social circumstances changing. And then they would meet every so often and do something together, be it yoga or some painting classes or having light Bollywood music, dance, things like that. So they got together, they came up with ideas. So the group was quite successful. I think we grew over the years. I rotated off the board a while back, but the group is still quite active and is doing extremely well. They hold galas, they fundraise, they have speakers, they write articles in the local newspapers. They have blood drives for bone marrow transplant registries. They did do a number of things. They're very well funded now. They give out scholarships for students in town. They conducted a very large survey of hundreds or thousands of people in the South Asian community in town. It was sort of getting a pulse of the needs of this community. And we quickly realized that this model minority concept is a myth, and many people would greatly appreciate additional help and guidance. And so it nailed down where the best, where to focus our efforts best. So I think it's been a well accepted and appreciated community resource in Houston.
Yeah, it sounds like you provide so much value to someone who's going through any cancer journey, from not just, decoding their diagnosis to support, and then post that, having a buddy to kind of go through everything and take care of themselves.
Well, as a South Asian myself, I think people need to be aware of what they're going to be facing, and what do you tell them?
Yeah, I think it starts even before one gets a diagnosis of cancer, right? If we can spread awareness in the community that there are things you can do for prevention of cancer, that's helpful. People that come to these talks then can disseminate that knowledge to their friends, family, relatives, children. Then comes sort of prevention, and then comes early detection, and only then do you come up with what can you do once you have cancer. But even the widespread adoption of best practices for, say, early detection of cancer, I don't think has penetrated the South Asian community sufficiently. The uptake rate for HPV vaccination among adolescent girls is not as high as one would expect with a well-to-do and educated community. It's the same for pap smears, mammograms, colonoscopies, PSA testing. I think this, we hope, has made a small dent in the awareness and acceptance of these procedures.
So I would, the question again, I just want to ask, what are the challenges that are different from, other communities that we South Asians face, whether it's in treatment or, how we kind of assess, um, I guess, our growth through these different, challenges?
Yeah, I think so. So I'll go back. There's still an awareness deficit between what we think we know and what we realize we. So, for instance, we all think that the incidence of colon cancer is much lower in South Asians than in the Caucasian community. But that was South Asians in India or South Asia, right? Once they come to the US, there's a shift in dietary patterns, in activity, and more of a sedentary lifestyle, all of which increases the risk of colorectal cancer. So it is incumbent on us to continue to do what it takes to reduce the risk and for early detection. The unique challenges we've noticed in patients relate to, you're admitted to the hospital and someone comes to you and asks, would you like the chaplaincy service to come to you? And then there's a patient that's Muslim or Hindu, and they may not be those services. So we went to all the hospitals in town and provided them copies of the Bhagavad Gita or the Quran, just so that those options exist in hospitals. I don't know if it's unique to Houston, but when we went around, we found that it was a service that was needed. Then I told you about the wigs, the need for the right kind of hair for a wig. Then it was with diet. Many patients are strictly vegetarian, and then they don't find the right kind of food that they would like to eat from the menu in the um, hospital meal service. I'm sure there are many others that we've encountered. These are the ones that come to mind now. But I think we realize that one needs to tailor recommendations to, and same with the dietitian. When the dietitian comes to you and says, I need you to take this many grams of protein and this much fiber and this many calories, and then the patient asks for examples, and you realize that all the examples are tailored to a more Western diet than an Eastern diet. Same, we noticed some difficulty, some language barriers, but not as much. Oftentimes, they're able to communicate quite well. But if needed, it's helpful for us to help with translation. Nowadays, everyone has a portable translator and things like that. But when we started, that wasn't there. Other unique challenges, I think we don't face quite as much of a challenge with insurance and finding ways to pay for treatment, but that is still occasionally a challenge. And that, again, someone who's skilled in all of this can help with. This is sort of a late scenario when patients pass away, family may not know how to bring the ashes or the body back to India, for instance. So one of our colleagues wrote an entire little book about last rites and what are the pujas that need to be done, what are the formalities for for performing a cremation here or taking the ashes back to India, things like that. So the challenge is once you start scratching the surface, there's lots that can be unearthed.
Is the last rites and the ashes, the cremation, is that uniquely different for each state, or is this book that you've created applicable to all states?
I think it's applicable to all states. What I've found is that, well, Houston, for instance, we have a great luxury that the Indian consulate is in Houston. So to take the urn, I think in principle, the airline can ask you, why are you doing this? And it's good to have a letter from the consulate. So for us, it's much easier because it's in town. So if you're in another state that doesn't have the consulate, then it's a little more challenging. But other than that, the rights, I'm sure it's different from one community in India to another community. So these may not be across the board applicable. When do you do, how many days of last rites? That I know, for instance, that varies from South Indian community to South Indian community and between South Indian and North Indian communities. So I don't think the book is prescriptive about those things, but there are unique challenges you face when dealing with something like this in the US. So this she explains very nicely. And it's in English, it's not in Sanskrit or something, so it's has mass appeal here.
So your lab is pioneering new strategies to make radiation therapy more effective while protecting healthy tissues. Could you explain your focus in simple terms?
Yeah. But I think you explained it perfectly. What we're trying to do is in the lab, trying to find ways to make the radiation therapy work better in cancers without damaging normal tissues, or find ways to make radiation less damaging to normal tissues. We've worked with chemotherapy drugs as radiation sensitizers of cancer. We've worked with immunotherapy. We've worked with botanicals and a large portion of the lab currently works with nanoparticles. But we work with that whole spectrum of things that sensitize tumors to radiation.
Interesting. So you had a question about the nanotechnology in the biologics, right, Dr. Prem?
I'd like to know more about the nanotechnology.
Sure. So, for instance, we found that if one can take nanoparticles to the tumor, and if the nanoparticle is metallic and a metal atom that has a large density of electrons around it, when the radiation comes and hits it, it scatters these electrons more so than normal cells atoms like hydrogen, oxygen, nitrogen. So then you create this shower of secondary electrons that causes oxidative stress, like we spoke about earlier, and that causes DNA damage and kills cancer cells. So we've worked extensively on taking gold nanoparticles to tumors, decorating them with peptides and antibodies, something that makes them sticky like Velcro to a cancer cell surface, get into the cell, and then hit those cells with radiation.
So do you plant the seed in there, or is there's no such thing?
So since the nanoparticle is really, really tiny, we think the most elegant way is to give it through the bloodstream and have it go either passively to the tumor or, because of the stickiness of the surface of the particle, attached to the tumor and stay there. The alternative is some groups try to directly inject metallic nanoparticles into tumors. Our approach has been to give them through the bloodstream and have them accumulate in the tumor. That's one idea. Yeah.
So what do you think? I just read about this is using RNA technique for specific tumors.
Right. So, as you know, the mRNA vaccine was developed and had huge success with COVID vaccinations. A similar approach for vaccinating against tumors would be to drive an immune response against the tumor. If you know what the antigen is that is most prevalent in the cancer. So if one can take, say, from a given patient, extract the tumor, there is no, at least as of now, single mRNA vaccine that would cover all kinds of tumors. But if one can take the tumor out of the patient and then extract from it the most immunogenic component and then get an mRNA vaccine against that, that would be a winning strategy. Again, not ready for prime time, but still being explored.
Yeah, it's interesting. Yeah, it's interesting.
So is any of this available right now for patients?
No, we haven't been at the stage where we can test this in patients. Our gold nanoparticle work is all exploratory and confined to the lab.
Do you think that
we've cured a bunch of mice with tumors?
with the whole nanoparticle concept, would it affect tumors anywhere in the body or only in a particular way?
Depending on the construct. If, say, one were to go after HER2 positive breast cancer, for instance, and I have decorated my nanoparticle with Herceptin, which is the antibody that binds to that receptor that's expressed in a subset of breast cancer patients, then it would be tailored to breast cancer and wouldn't work for a brain tumor or something else. So depending on what the sticky part of the nanoparticle is, it would be specific to that cancer, not another one. If one uses just a bland particle which doesn't have any sticky substance on the surface, then one's relying on the leakiness of tumor blood vessels compared to normal tissue blood vessels, and they just leak into the tumor. Then it could be applicable across a spectrum of cancers.
So is it safe to say this is one of the most exciting breakthroughs in radiation oncology?
I think it's the thing that's most exciting to us. I'm not sure I would go so far as to say it's the most exciting breakthrough in the field. But for us, it's an area of great interest. So we can make our particles stimulus responsive. We've found ways to get them from the injection site to the tumor by many methods so that within the bloodstream they behave sort of like benign particles. When they get to the tumor, they convert to something that you have some functionality for. So we think of it as Dr. Jekyll and Mr. Hyde. In the bloodstream, we want it to be a Dr. Jekyll, a good, well-behaved guy. And then when we get to the tumor, we want it to mutate and become a Mr. Hyde and the bad guy. And so to make these stimuli responsive particles, we've got a number of tricks to rely on the acidity in the tumor microenvironment, the low pH, the low oxygen tension, the enzymes that cancers use to evade through, like you were mentioning, collagen. These cancers have a way of migrating by breaking open collagen and sort of penetrating tissues. So since those enzymes are prevalent in the tumor microenvironment, we sort of hijack that system and use those enzymes to convert our particles from good guys to bad guys, only in the tumor, things like that.
So is there any downside? I mean, are there ill effects from what have you?
It depends on the specificity of the particle. So if one can get a huge differential between tumor and normal tissue, nothing's a perfect silver bullet. So you know that you're going to have some accumulation in normal tissues. If you can minimize that to the extent possible and maximize what's in the tumor, then you get this therapeutic ratio, which is greater benefit against the tumor with very little side effect.
So I think that's a very exciting way of.
I think there's a lot to this.
Yeah.
You know?
Yeah. And how soon do you think this would be available, to
We're in the process of trying to get this to the FDA, but it's a long haul. Yeah. So we've done numerous experiments showing that it's effective in cells in culture and in mice. We think we can make this in a sterile, scalable, consistent manner, which is required, and in large enough batches to be used in patients. Now we need to do toxicity studies in a very special way for the FDA to approve it. And those are done in 2 animal species, and we're just about embarking on those studies, which tend to be quite expensive. And once we have that, then we apply for an investigational new drug application to the FDA and then embark on clinical trials. So we're still a little ways away. That road is quite expensive, so it's not easily undertaken with just NIH grants, which is what we subsist on.
at least 5 years away?
That's right. Yeah.
Okay. So yeah, I mean, I think this is a fantastic new innovation for someone who has to go through radiation and other, treatments, a lot less invasive and better on side effects. So I think if you could give one message of hope to patients and families facing breast cancer today, what would it be?
I think we've made tremendous progress in breast cancer treatments since the old days of a radical mastectomy, which was quite morbid a procedure, to much gentler procedures these days. The toxicity is manageable. We're much better at sort of divvying up the pie of all breast cancers and saying there are subsets, knowing what these subsets are, and tailoring treatment specifically to that subset of breast cancers with novel antibody drug conjugates, immunotherapies that are completely changing the landscape of breast cancer treatment today. So I think a patient diagnosed with breast cancer today has a completely different outlook than someone diagnosed even just 20 years ago.
Wow, that's amazing. The outlook is much better than what most people would like to think it is. So thank you for sharing that.
Well, that's an important message to share with patients and people who are interested in knowing more.
Yeah. One thing when I going back to that stint where I spent at ICAN, the Indian American Cancer Network in town, one thing I emphasized in that group whenever we fielded calls from people who've just been diagnosed is it's not unacceptable to seek a second opinion. So always get another opinion. Make sure you're doing things correctly the first time around. There's no tearing rush to get started with treatment the very next day. You don't have to go to surgery the day you're diagnosed. Oftentimes, you may need some chemotherapy before the surgery and then go get the surgery. So if you rush into things, sometimes you can't undo what was done. So take your time, fully stage the disease, get scans to make sure it hasn't spread anywhere. Figure out on pathology that it is what you think it is. Get another opinion. Take your time. And then once you start, then don't look back. Complete everything per the treatment team's recommendations.
I think that's such an important message.
That's a very smart one.
Yeah, because most people get so scared, they just want to make sure they get on that journey fast, and then they miss out on the things that they should have paid attention to right from the beginning. So I think it's hope for the patients. It's also giving people this idea that take your time, don't rush into anything. There's no rush. So thank you so much. Thank you so much for being on the podcast
You're
with us.
welcome. It was nice meeting you.
Pleasure talking to you.
Take
Thank
care.
you so much.
Likewise.
Today's conversation reminded us that while breast cancer is a serious diagnosis, it's also a story of hope, innovation, and community. Survival rates have never been higher, over 90% overall, and nearly 99% when caught early. That means every screening, every prevention effort, and every breakthrough matters. We are deeply grateful to Dr. Sunil Krishnan, Dr. Jessica Jones, and Dr. Pram for not just sharing their expertise, but also sharing their wisdom, their compassion, and their commitment to patients and families. If you found this episode helpful, please share it with someone who needs encouragement today. And don't forget to follow us on Instagram and on YouTube at Mood Food Podcast for more conversations that heal, inspire, and empower. The link is in our show notes.